You're listening to the Pre-Hospital Care podcast on the Medics Academy network.
Neurodiversity is something paramedics encounter every day, whether we recognise it or not. And certainly autism and ADHD are often hidden, frequently overlapping, and too easily misunderstood within pre-hospital care. So today on the podcast, I'm joined by David Birch, our guest, to explore how ADHD and autism are present on scene, and indeed why behaviours are so often mislabelled as non-compliance or intoxication, and what some of the practical patient-centred adjustments we can make to make a difference to care. Welcome to the podcast, David.
Thank you very much. I'll just give you a bit of a brief rundown of myself. Started paramedics in 2007. And in 2010, big year for me, got engaged, got married, also got told the wife was pregnant with our first son, who was born in 2011, and second son arrived in 2012. Everything seemed to be going all right. The older boy wasn't quite hitting his markers as much as other kids were, a bit delayed in speech, but, I've just thought late bloomer. Nothing too much about it, and it really hit home. He was at a party with about 20 kids in a yard, kids going nuts, and then he's off standing by himself, actually playing with the water in a bucket, and that's when it really hit with me that my boy was quite different to the other kids. And so we went through the testing regime, and he was diagnosed with level 2 autism, inattentive ADHD, and also anxiety. Second child, whilst he was hitting his markers, he was a bit more rambunctious than the other boy, and so we just put it down to him being a bit high-spirited. But it turns out more for him it was ADHD, and his ADHD, because he's the hyperactive variant of ADHD, so was masking the fact that he also had autism, and so we didn't get him the autism diagnosis until the age of 8. And so in my role as a paramedic, I've seen that we do encounter these groups of people quite often in our roles, and they're very littly understood. It's more the stuff you see on TV and that sort of thing, or movies, that you think, and they're not really an accurate representation. And so I thought people were asked to do presentations on topics, and I thought I'd bring this one to my local area, and it was well received. And so from there, I've tried to put the word out to help us deal with this group of patients that in their time of need, just need that a bit more support, kit gloves sort of approach at times. Yeah. So thank you for letting me speak today.
Oh, listen, pleasure. Absolute pleasure, David. And as you said, it's really important just to shine a light, just to raise awareness, really, and indeed understanding into autism as a hidden disability, really, because it's not always really apparent that this is at play. But could I get you to really maybe unpack for us some of the cues that paramedics could pick up on that maybe are commonly missed?
It's often considered a hidden disability because, and if I can just hold you up a photo here, now that's me and my two sons, okay? And looking at that photo, especially of my two boys, without any additional information, you'd have no idea which one has autism, which one has ADHD, which one is hyperactive, which one has the inattentive. And so it's a hidden disability, as in just by looking at someone without additional information, you're not going to know what's going on. And it's more when you observe the behaviour that you're more likely to see that there's actually something more at play here. And as for how do you recognise that someone has ADHD, autism, or both, the obvious one that we all get told about quite often is the poor eye contact. And when you're speaking with someone, your facial expressions and what have you, and like with the hand gestures and what have you, that portrays just as much information as what the actual spoken word does. And that is actually quite a lot for a neurodivergent person to take in. And so for the neurodivergent person, they don't get that nuance of the intent of what the conversation is. And it can be quite overwhelming for them. And also, because they don't want to misinterpret what's being said, they tend to not make eye contact. And so that's probably one of the obvious clues that we get that someone might have neurodivergence. And I'll just quickly say, if someone's not making eye contact with you, it's not the old school, look at me when you're talking to you. They're doing it for a reason. And if you force them to make eye contact with you, you're likely to enact a negative response. Another one is called stimming. Now, it's unusual movements, behaviors, and sounds. And it looks unusual because we're just not used to it. Now, my son's common form of stimming is he either holds his hands in front of his face or behind his head like that. And normally when me or my wife see that, we know that something's going on. He's either upset, he's unsure, he needs some sort of support or reassurance. And so it's more for the neurodivergent person to regulate themselves or to calm themselves. Okay, another one is echolalia, which sort of gives it away with the first part of it, the echo. So it's repeating phrases, babble, sentences. So if someone asks you a question, instead of actually answering the question, they'll repeat the question. And what it is for the neurodivergent person is they're trying to buy themselves some time to understand what's being asked of them. So instead of answering the question, they just repeat the words to give themselves a bit more time. Because when you and I are speaking, it's almost immediate back and forth. Whereas with a neurodivergent person, there's going to be a bit of a delay while they try to understand what's being said, and so they can form a correct response. And then we've got the stereotype behaviors, so where they get stuck in certain habits, interests, behaviors. It's part of their daily life. Most neurodivergent people, their routine is like their safe place. They don't like changes to routine. And also can be true for holding material objects. My son, for whatever reason, in his pocket is his fidget spinner, which I understand that. But there's a golf ball and a couple of other bits and pieces in there. They're just for him, maybe for tactile stimulation, I don't know. But it can help him regulate. And so I let him go to school with all those stuff in his pocket, even though he's got one side pocket just bulging full of stuff.
Yeah, indeed. No, indeed. And actually, it's really important just to understand, like you said, the different manifestations of ADHD and autism. Just to understand that not every patient's the same, and there is probably a reason why, to your point, they are manifesting in the way they do. Could I get you to speak to the high rate of co-occurrence, David, between autism and ADHD, and then maybe indeed how paramedics should approach assessment when both may be present and or overlapping?
ADHD and autism, depending on where your information comes from, but the overlap is upwards of about 80%. But 50 is probably, I don't know where it actually falls in that sort of thing. And if someone has autism, chances are they also have ADHD, and vice versa. If someone has ADHD, they may have autism. There's a heap of other co-occurring conditions. The two most common is depression and anxiety, for those obvious reasons, as in they're in a world that they're not sort of made for. The Australian comedian Hannah Gatsby, who's also on the spectrum, her description of trying to understand what it's like being an autistic person, she said, it's like being in a party where you're either the only sober person and everyone is very drunk, or you're very drunk and everyone is sober. It's sort of everything is so different in those sort of situations. But as well as depression, anxiety, the other main ones are opposition defiance disorder, OCD, Tourette's, just to name a few. So if you say that they've got ADHD, autism, just keep in the back of your mind that they're going to have maybe one, if not all, of these conditions, and then you may have to tailor your approach that way. So just think, okay, this person could be very anxious. I need to make sure I can reduce the anxiety levels, reduce the sensory input, just to hopefully help this patient, because we're there to help them, but to help them we need to get information, and sometimes we can be a bit sort of, by our nature, we're impatient. We just want to get in there and get things fixed, and sometimes just taking your time is much better approach.
So just looking at really how we can maybe not misinterpret some of these signs, David, within pre-hospital care. Could I get you to speak to some of the risks really of misinterpretation, of some of these signs and symptoms when we're practicing day to day?
Common misinterpretations of someone who is neurodivergent is intoxication or drug affected, and another one would be someone, say, having a hypo in that regard. The best way I can probably describe it is a case that I went to, and if I ever use an example, it's always a 20-year-old autistic male. And so what was happening is he was sober and he was driving his drunk mates home from a party, and he was involved in an accident with a person who was drunk, and the occupants of his vehicle were drunk. And the police got there first, and so of course there's about half a dozen drunk persons, and the drunk driver was, when he got out of the car, started yelling at the autistic person, and so he's gone into shutdown mode, and to try help himself he's also doing the stimming. So the police, when they turn up, through no fault of his own, he just assumes this person is drunk, and we all probably would have made the same assessment, because everyone else is drunk. You've got a person who's not speaking and they're stimming because they're in shutdown mode because of all this overstimulation. The police actually breath tested him, and he, of course, he passed the breath testing. So, of course, he's thinking something's wrong here. And when we arrived, it was as he was instructing his other officer to go get another breath tester to test him again. And as I approached him, I could see that the person was stimming, so it sort of gave me a bit of an idea of what was going on. And I just asked, is this guy autistic? And his drunk mates are like yelling at, yeah, he is. And then, so what we did is we just sat with him till he sort of could regain his, and then just asked him, like when he was able to answer, if he was autistic. We moved him into the ambulance away from the show that was going on outside, and then explained it to the police that, no, your machine's not faulty. He actually is sober. He's just overwhelmed. And once we explained that to the police, they were like, oh, okay, all right. Their involvement there was no more. And that's how someone who is neurodivergent, how when they're stressed, they can present differently to someone else. Yeah. I mean, we eventually just got his parents to come and pick him up, because that was the best outcome that we thought we could get for the patient.
Yeah, indeed. No, indeed. And like you said, it's really good to both identify that and also bring others along on that journey, namely the police or indeed pre-hospital colleagues. Could I get you to speak to really just how paramedics can realistically balance neurodivergent needs with operational pressures? Because absolutely in pre-hospital care, the crew are on the clock. There's constantly demand and indeed different work stresses. But could I just get you to speak to really how we can maybe balance these operational pressures with just taking our time with these patients? You just gave a fantastic example there of taking the patient away into the ambulance, letting them calm down, and just taking some of that stimulus away from them.
Yeah, I don't think there's an organisation in paramedics that isn't under pressure to get back out there, because there's always cases backing up, and operational demands, response times, the KPIs, they're always there. There's always someone to say, can you please clear, because there's another case pending. And so we sort of have to make our communications and our supervisors and that know that these are very complex cases when we're dealing with the many different aspects of the neurodivergent patient. And so I always think as soon as you can, get a call in nice and early, let them know that this is probably going to take a little bit more time than what the average case was. And you're going to need more time than to deal with that patient. And especially if the patient is highly escalated and they're in meltdown or about to have meltdown, it's best that you let the patient de-escalate themselves than you try force the resolution, because I think we all know that yelling at someone to calm down has never, ever worked in getting someone to calm down. So if you can get them to get to a level of social engagement, that's a lot better than you trying to force the resolution, because you'll only prolong the situation. And if worst case scenario, you'll escalate them higher to the fact that they will go into a meltdown. And the second part of the time sort of thing is if you're going into a residence and you're there because one person is like escalated, having a meltdown, the chances are that the parent, caregiver, caseworker, like they're under a high cognitive load, because especially parents, they've been dealing with this like 24 hours, 7 days a week, month after month, year after year. There's no sort of respite, especially for the really, like if the really high case ones, like the non-verbal sort of patients that really need a lot more support than, and like there's no training out there for parents, so they're just doing the best they can with what they've got. And so they're probably going to need time as well to help manage this situation and try and make the best of the situation for the neurodivergent person. So yeah, these situations can be quite tricky and hard to deal with. And so a call nice and early, and then if it's progressing on, just a follow-up call, just to say, listen, we're really going to need more time here to de-escalate this situation. Because the simple thing would be to just go in, throw them in the restrain or sedate, and that's not the way we should be treating these sort of cases.
Yeah, indeed. No, I fully agree, actually. David, you describe sensory overload well for autistic patients. I wondered if I could get you to really unpack how sensory processing differs or indeed overload or overlaps within ADHD, particularly in the ambulance environment.
Yeah. So neurodiverse persons, they can go into sensory overload because their senses are quite heightened. So any of the senses, like sight, sound, smell, touch, and taste, or their tactile stimulation, it can really send their senses into overdrive, overstimulated. It can raise their level of anxieties, their frustrations, and it initiates that fight, flight, or freeze, or could actually go even further than that into a more aggressive behaviour, or it goes the other way where they just go completely shut down. So to try reduce the sensory overload in the pre-hospital setting, when you think of an ambulance, there's lights everywhere. They're normally very bright, and because they normally have to be for the type of work we do. There's always a light beeping somewhere. There's something noise going off somewhere. There's sounds and smells that are all strange and different to the neurodiverse person. And so if you take them from their home or wherever it is the person is, the ambulance could be quite a confronting place for them to be. So, it's one of those things, the best as you can. Like if you are transporting, you need to like make it more accommodating. Dim the lights, turn the sounds down. If you have to, turn the radio down to the bare minimum. And if you can, maybe something to distract them. Normally a phone or iPad's not bad. But yeah, because it can be quite a overstimulating place being in an ambulance, especially, with the blood pressure cuff going off every 5 minutes and that sort of thing. There's sensors there that they're going too often, too many times for them to regulate what's going on.
Yeah, indeed. I just wondered if you could just really go further, David, really in describing stimming as a regulatory behavior. In ADHD, you described, self-regulation looking quite different in different patients, some fidgeting, some movement, some verbally impulsive. Could I get you to really maybe just speak to how crews should interpret and manage, I guess, the spectrum of behavior really safely and to your point, just almost permissively, acknowledge it, allow it, and allow the patient to come back to baseline.
You're actually correct in everything you just said there. The allowing part is most important. So it's unusual sounds, behaviours to self-stimulate, self-regulate, to calm. The behaviours look unusual. We're just not used to it. And most commonly it's because there's just an overload, anxiety and stress. Can let the person continue for as long. Normally it's not for, hours on end sort of thing. It's normally just in the moment to get them feeling okay, or get them feels better. I know sometimes with the stimming, because if the person's like doing this, it makes it almost impossible to get a blood pressure. And you think to yourself, well, if they're doing that, the blood pressure is going to be, at least 100 systolic. They're going to have a good pulse. So you are doing a vital sign survey without actually getting physical numbers. And if you can redirect the behavior to allow you to do that, you've done well. Sometimes, though, the stimming behavior can be quite confronting, and it can be extremely physical in nature. I've been to it was a female, but I'll say it's 20 male just for the sake of it, who, when she was overwhelmed, would pull out just clumps of hair. And when I was talking to the mother, she said, "Oh yeah, that's like her stimming. That's what she does." And it's not just like one or two hairs. She was pulling out big handfuls of it. And when she gets to that point, the mum says, "Oh yeah, she's now gone past the point of no return. There's like we will not be getting her back for quite some time." And so in the end, we did actually have to sedate that patient, because we would have been on scene for longer than what we was an acceptable sort of thing. Plus, the mum had already indicated there was no way we could de-escalate, get her back to a normal, cognitive level that we could actually engage with. And so stimming sometimes can be quite confronting because of the physical nature of it.
Yeah, which makes sense, David, which absolutely makes sense. I'm just looking at medication because it is indeed extremely relevant in neurodivergent patients. From a pre-hospital perspective, could I get you to speak to really what paramedics should understand about stimulant and non-stimulant ADHD medications during acute illness or trauma?
Yeah, so most people who are ADHD, autism, they take stimulant medications or non-stimulant medications, and the purpose is central nervous stimulants, and it's to promote focus, limit hyperactivity, and impulse control. I don't know where you are, but I think the names pretty much are the same all over. But if a patient takes Ritalin, Concerta, Vyvanse, dexamethamphetamine, Adderall, Intuitive, there's a good chance that they're going to be on the autism spectrum or ADHD or both. Now, I found this confusing when I first sort of tried to get my head around it, because these are stimulant medications, yet they're to help like promote calm with improving focus, impulse control, and to what we think of stimulant medications. And of course, when in our line of work, when we think stimulant medications, we're more thinking along the lines of your cocaines, your meth, and that sort of thing. And you're thinking, well, they don't really promote impulse control and focus, but they work differently. And so they use these medications for that. So because like my boys, like we'll get a phone call if they're at school at about 11 o'clock, and as soon as I hear that phone call, I realise that forgot to have their meds in the morning, because they won't be settled in the classroom. They won't be able to take the information in because they're off doing other things. Now, there was a line of thought thinking that, like if someone takes these drugs, it's just a gateway then for them to take the other forms of stimulants like your ice and your cocaine. But they're more likely not to end up down that road, because they're taking these, your Ritalin and such, to be more focused and to limit their impulse control, and therefore they're making clearer decisions. And it's when you're not got good impulse control and you're not focused, that's when you tend to drift off to take these other sort of medications.
So just looking at communication, you've spoken to communication throughout the interview, actually, David, and could I get you to really maybe unpack really what adjustments should paramedics make when communicating with an adult with ADHD under stress or indeed in crisis?
Yeah. So you got to allow the neurodivergent person time to process the information. I think I touched on it earlier with that back and forth, and then the neurodivergent person making more time to answer. So you have to be patient and let them answer in their own time, and let them, like the thinking time, so to speak. And to assist with this, you have to be quite literal with what you're asking for. So put your communication style in like a black and white format. So the answer can't be something that requires a lot of executive thinking and what have you. Just that, like a yes or no sort of answer. If that's, like what's the sort of answer you do need for what you're trying to work out. Also, avoid like slang or sarcasm, figurative language, expressions like what's up your sleeve, because the chances are they'll start looking for what's up their sleeve. I saw a video once of a kid. He was playing t-ball with his dad, and his dad's trying to give him instructions on how to bat. And the kid was swinging and missing, and the dad's just yelled out, "Keep your eye on the ball," to which the young child put his eye on the ball, because that's what he assumed his dad wanted him to do. And it's that sort of language where there can be like, double meanings and things like that we have to try to avoid.
Yeah, indeed, and like you said, I think there's probably a literal sense of or interpretation of sayings, and actually, to your point, being very cautious and careful about the way in which you communicate, and indeed the inferences of that communication. Just looking at how we can sort of reframe behavior through a neurodivergent lens, David, and maybe get pre-hospital staff to change decision making on scene through just, like you said, an initial acknowledgement and recognition of maybe this symptomatology, and therefore take a different posture, pivot, and change the communication style, change the time given to this patient, allow, as you were saying before, de-escalation, but also change decision making. Could I get you to really just speak to that?
Yeah. So I think I've jumped ahead here. All right. Yeah. So sometimes neurodiverse patients can be seen as non-compliant, and that's because they get stuck in their hyper focus, and it's very hard to redirect them into doing what you require. Another side of that is a thing called pathological demand avoidance, and so it's the demand avoidance. So they don't want to do something because they realize it's going to put too much stress on their system. So something like you wanting to get them to do a vital signs survey or get them into the ambulance, and there's flat out refusal because they realize it's going to overwhelm their system. So it's like a self-protective mechanism that they've engaged there.
Yeah, which makes sense, and it's just acknowledging those self-protective mechanisms, I think, and seeing them for what they are. Just you speak to really emphasizing building rapport and looking for commonality of shared interests. In high stress ADHD presentations, could you get to really maybe just give us some practical strategies, really, how crews could help build rapport and trust with neurodivergent patients?
Yeah, well, I think you understand too. It's not just neurodivergent patients. Any patient we go to, we need to build like a rapport and a trust with them, and then to get the case to work for both them and for us. So the simple ones, just keep things calm as you can, talk softly, no sudden movements, and model the behavior that you would like the patient to display. And just to take that to just another little level, is once again a little sidetrack here. I went to a patient who he punched a window when he was overwhelmed and split his arm there. Luckily for me, didn't really rupture any big vessels because there was no massive bleed or anything. Best way to describe it was when you've got a hot dog in the hot water for too long and it splits. That's what his arm looked like. And of course, I realized I had to get that arm bandaged up as quick as I could. And so I kept on pointing at my arm, and then I pointed his arm, and then I pointed my arm, and then I bandaged my arm. And then I pointed back at his arm, and he saw my bandaged arm, and he let me then bandage his arm. So just things like that can really help you. So that modeling of behavior. Also, and this doesn't just apply to neurodivergent patients, it applies to anyone. It's a team game. So this is why if you've got a male-female crew, it's really good because they might not like you, but they prefer a female. They might not like you because you're a bit older, and they might like the person who you're working with is a bit younger, or vice versa. And we get a bit sort of worked up, like I'm the patient care officer. That's sort of, for any person, that goes out the window. Whoever's going to be able to get the best result, they're the one that's going to treat. So if the person I don't get a good response with what my partner does, I'm ready to let that go and go, okay, then I'll support that person in what needs to get that person to hospital. Sometimes you have to recruit someone from outside of you and your partner. You might need to get like a family member, a social worker, psychologist, friend, anyone to help you with your. So if they have to sit in if your service will allow this sort of thing to happen, if they can sit in the back with you and that keeps things moving along, I say that's not a bad idea. And sometimes technology is a great thing because neurodiverse people, technology seems to be their friend because it's something they can rely on because it's same all the time. There's no sort of ups and downs normally with it. So an iPad, an iPhone, if you're going to lend an iPad or an iPhone or use an iPad and iPhone, my biggest suggestion is use theirs, not yours, because at some point you'll need to get that thing back. And I had to wait till the end of a half-hour episode of, might have been a comedy like Friends, I'm not sure. But until I could get the iPad back because they were locked into watching that show on my iPad. So there's if there's one take-home message, that's the one I will go with today.
Just looking at from your experience, really, because absolutely you have lived experience of dealing with your sons with ADHD and autism. Could I get you to speak to really some of the, I guess in a way, the system failures that you see that maybe fail neurodivergent patients, particularly those with ADHD?
Yeah, well, it's more awareness and understanding, and paramedics, medical staff generally, like, we've received little to no education on it. I've gone out of my way to understand, because of my two boys being neurodivergent, to make sure that I have a better understanding of the situation. And so sometimes, because of that lack of understanding, taking a neurodivergent person to hospital does them a bit of a disservice, when psychologist, a therapist, a caregiver might be a better option for them. At the moment, there's not that much education out there unless you're prepared to go look for it. Things like this also obviously help. If they've got like a fracture, a laceration, having a STEMI, just because they're neurodivergent doesn't mean you get to leave them at home. Those ones actually do have to go to hospital. And when we do take people to hospital, sometimes a courtesy call is not a bad idea. Ring up, let them know about the neurodiversity of the patient, and then what accommodations the hospital can make for them. And I've always found that the triage area, normally, because there's normally numerous people there, it's chaotic, it's noisy. Sometimes send your partner in to get the triage nurse, bring them out to the ambulance where it's a nice, calmer environment, get them triaged that way, and see if you can get them to a quiet part of the ED, the emergency department, which there's probably no quiet part of the emergency department, but they might be able to find a cube in the back corner, dim the lights, turn down whatever sounds they can. Sometimes something like the family room, if the hospital has one, sometimes that can be utilised as a better option, so you don't enact those fight-flight responses when you get to hospital, which, if you've done all the good work, you've got them from the front door all the way to the hospital's doors, and then you don't want them then having their meltdown, because you've really done the hard yards, and then you just don't want to lose that last little bit.
As we come into land on the conversation, could I just get you to really, I guess in a way, share a top of mind thought around, if you could change one aspect of paramedic education around ADHD and autism, what would have the biggest immediate impact on patient outcome?
As a patient group, and as society in general, not everyone is a little bit autistic. And just because someone's a bit shy or odd doesn't mean they're on the spectrum. Neurodiversity, it isn't linear. It's not down one end, you've got someone who's not like the least neurodivergent person at all the way up to the most neurodivergent person, and then everyone else sort of falls in the middle there somewhere. It's not a straight line. And the way I'll use to describe it is when you go into your paint store, because you're going to be remodeling the house, and it's not a case of you walk on in and there's the white, and you go down through the greys and there's the black there. It's more a case of there's a massive, massive color chart. You've got your white, yellow, orange, red, blues, greens, purples, and all the other different shades in between. And within those shades, then you've got your matte finish of your paint, you've got your glossy, you've got your textured finishes. So it's a very, very huge, huge spectrum. No two people on the autism spectrum or ADHD spectrum are alike, as no two people are alike. So it's a very, very diverse group. And so I think if we could keep that in mind when we treat these patients, treat the individual, not the stereotype that you've heard of, we can then better support this group of people. And then from there, we can better outcomes. And we won't get the whole, that they feel like they've just been dragged to hospital, processed, then punted back out. We'll get that where they actually think they've been supported, they've got care, and they feel of value because we're treating them appropriately.
Yeah, listen, that makes sense. Absolutely. David, listen, thank you for the past 45 minutes. It's fantastic to get your thoughts and indeed lived experience. We are going to signpost to your fantastic lecture online on YouTube, because I think that's a great resource for paramedics to go away with and watch. And to your point, raise awareness and
Thank you
raise.
so much.
Yeah, listen, it's an absolute pleasure. Listen, thank you for joining us today, and we'll speak to you again soon. Many thanks.
Thank you for your time, and I've appreciated being on your podcast. Thank you so much.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.